with considerations of your very good questions. And I'm going to advance to the topic that I prepared for today is psychiatric differential diagnosis in the pediatric clinic, which is a much longer and a much more extensive presentation than I've given previously. You know, as we've talked about before, TPIC is really set up to be much more case-oriented, and that the presentation that I offer is short. The topic, however, is a much more extensive one that really behooves me to make a longer presentation. But I think that we could actually move through it by talking about the highlights and keeping our minds on the overall picture. Because this is really a talk that, while I talk about it as differential diagnosis, another title for it is, if not ADHD, what is it? Because so often youth are referred specifically for evaluation of and medication for ADHD, right? Have you had that experience? Go ahead.
You know, I was laughing because that's so true. You know, I mean, when you have a parent, the first thing that the parent mentions is that they suspect that. Yeah.
So when we talk about differential diagnosis in the pediatric clinic, it really is, well, if it's not ADHD, what is it then? Well, when we have the opportunity for comprehensive clinical assessment, we frequently find that youth often have other, often coexisting conditions that impair their learning and other aspects of their life. This is oriented to the school, not only because of the work I do, but this is where the concerns often come up that are then communicated to parents. However, we find that it's important to consider the various diagnostic domains which feature hyperactivity, impulsivity, and distractibility leading to off-task behaviors, which are really the hallmark features of ADHD. So our goal is to consider these major diagnostic domains during behavioral health assessment. For example, a school may contact a parent about their third grade son. And the school may even ask for an evaluation of ADHD in terms of asking the pediatrician to diagnose ADHD and prescribe Ritalin. Well, we know that the referral does not make the diagnosis and prescribe treatment, and we really need to consider the diagnostic possibilities. Well, we need more information in order to do that. Well, how do we find that information? Where do we go? From whom do we receive it? Well, ideally, if we could contact the teacher, there are various ways of doing this, and we may have them complete a Vanderbilt, known as the niche Q, for ADHD and other disruptive behaviors, and they may write some comments on it that the student doesn't pay attention, doesn't listen, assignments are incomplete, often not turned in, the student seems like he's somewhere else. And we may ask, well, does he act before thinking, or is he impulsive? And the teacher may say sometimes. At times, he doesn't follow rules and directives. We want to know, is this youth hyperactive? And the teacher says, today, no, yesterday, yes. Well, intermittently. Oh, is he aggressive? Well, he's been verbally aggressive to teacher and peers and physically aggressive to peers. He's easily annoyed and frustrated. And when asking what's known about what's going on at home and does mom know about this, Well, the teacher may say, no, we're not able to reach the mom, so we sent the referral right to you. Well, we can ask a school counselor who reports there have been poor academics and some behavioral problems this year after he'd been retained in the 3rd grade following many 2nd and 3rd grade absences the past 2 years. He's had referrals to the assistant principal for the aggression that was just mentioned. He's often teased and bullied by his peers, and he's being tested for special ed. Ah, that's really a gold mine right there for information. And when the counselor calls home, the counselor is finding out that it's chaotic at home and it's hard to reach mom. So we go to the school nurse, and earlier this week we had a nurse on the webinar who said, yes, this is the kind of thing that's often seen in these students in elementary school. Multiple somatic complaints. The last 2 years, especially digestive tract and headaches, so tummy aches and headaches. However, his annual health screen and physical exam the past 2 years has been essentially normal, except he's overweight. And he's been having frequent visits to the school nurse for vague complaints and unclear reasons. He appears sad and needy. So we asked the educational diagnostician what's being found. She described some preliminary findings of a psychoeducational evaluation in progress, that the cognitive testing is showing deficient verbal intelligence, and there's a disparity between that low score and a low average score in nonverbal intelligence. So we can't interpret this as a full-scale IQ. We can mostly see there's the disparity and there's deficient verbal intelligence. Along with that are observed slow verbal or language processing and intermittent distractibility. No evident vision or hearing deficits, as the nurse reports as well. The performance testing is pending, and he's been referred to a speech and language therapist for evaluation. So the question comes, does Spivey have ADHD? If so, which type? What's the evidence for? What's the evidence against? Some clues include age of onset, variable features, or are they persistent features? Let's take a look at that. Because numerous psychiatric problems in youth feature these ADHD hallmarks, and concentration difficulties alone are symptomatic of virtually every psychiatric disorder, all of them listed, that is, in the DSM-4, and many related subsyndromal conditions. Well, it's become a practice standard that if a variety of disorders can be mistaken for ADHD and can co-occur. And when I say it's a practice standard, this is pointed out in the American Academy of Child and Adolescent Psychiatry's practice parameter for the assessment and treatment of ADHD. We're really encouraged to think about what else might be going on. And there's some empirical support from a meta-analysis in Madison study and some other studies. Madison found that various mental health issues underlie disruptive behavior at school. Not only ADHD, but other disruptive behaviors, mood, anxiety, adjustment, substance use, learning language, and other developmental disorders. And I'd have to say that really squares up with my experience in working in school clinics and in the pediatric clinic providing psychiatric services. Well, what else can present like ADHD in youth? And that brings us back to our main objective, to identify the major diagnostic domains which feature youth distractibility, impulsivity, and hyperactivity. And here's essentially the list of the differential diagnostic domains which have these ADHD hallmark features. In addition to ADHD, oppositional oppositional defiant disorder and conduct disorder, and features of those are under other disruptive behavior disorders. Mood disorders like depression and bipolarity, psychosis, any of the anxiety disorders including PTSD, disrupted early attachment, which impacts memory, dissociative disorders, neuropsych considerations, sleep problems, substance abuse, pervasive developmental disorders, other developmental considerations, and medical conditions. And now we're going to embark on a survey of all of these. How does that sound to you, Hernan?
Sounds very good. I feel a little bit guilty about being the only recipient of this good source of knowledge, okay?
It's my pleasure to go over this. This is a topic that's so dear to my heart. It rings throughout my years of practice.
Good.
And we also want to look at what are the psychiatric disorders and what are their causes, which brings on objectives of defining a psychiatric disorder, distinguishing disorders from subsyndromal conditions, and understanding etiology via a biopsychosocial model. Well, the psychiatric disorder is described in a great section in the DSM, probably the best section I've ever read in the DSM. Describes a psychiatric disorder as severe and pervasive, so it keeps going on across different settings. It's persistent or recurrent across time, causes impairment, and has biopsychosocial origins. Well, we know that the biopsychosocial model is being used to describe psychiatric disorders in addition to medical illnesses like asthma after George Engel came up with it to explain heart disease. And that it explains etiology by identifying genetic predisposition and other constitutional aspects, giving credence to psychological experiences as well as social and environmental factors. And in reviewing ADHD, we know that the hallmark features are, again, hyperactivity, impulsivity, and distractibility, and that it's actually a deficiency in concentration rather than attention. It's really a bit of a misnomer to call it attention deficit. There's essentially an overabundance of attention to surrounding objects and events, while difficulty concentrating on what's immediately in front of the individual and remaining on task with that. The three types include 1 to 3 of these hallmark features, with the predominantly inattentive type having inattention only, the combined type having all 3, and the inattentive type might be a bit of a different entity in that it has different genetics and pharmacologic responses, at least to some medications, than the other 2 types. And characteristic of ADHD is the early onset, that is by 1st grade, and impairing symptoms from the ADHD features. So if the teen we're talking about earlier says, well, Mom, I really think I have ADHD. I haven't been able to concentrate in class this year, as though that's something new, it most likely isn't ADHD. It could be some preoccupation with their internal search to better understand their identity, or the coexisting depression and other conditions that can go along with that. And how do we evaluate ADHD? Well, ADHD is a clinical diagnosis made by comprehensive assessment. And instruments such as the Vanderbilt and some others lend to that comprehensive assessment. The Vanderbilt really guides the pediatrician and other primary care providers in making a diagnosis of ADHD. But ideally, we consider those instruments along with other available sources of information, including the interview with the youth and the parent and family, observations made by the teacher and the parent, which are reported in those instruments, school records, other collateral information. It's very hard to make the diagnosis based on a single clinic visit. It really is not based on that, but we're often pressured to do that. Nor is it made on the basis of a single classroom or home rating. It's really made on the basis of behavior across multiple settings, and that there's no test for ADHD. Students are not tested for ADHD. Nor is it needed to refer students for neuropsychological testing for ADHD. Although neuropsychological testing and other testing can support the diagnosis and provide some additional useful information. Well, in identifying what causes ADHD, it's largely a neurologic condition, while psychosocial factors contribute to the severity. And it's the neurologic condition that can make it very attractive for parents to have their child diagnosed for ADHD, and that there's medication that really helps the condition without needing to have other therapies necessarily. But the psychosocial factors can contribute to the severity of ADHD. And when there are other comorbidities, such as depression and anxiety, there are psychosocial factors that need to be dealt with. ADHD probably results from delayed brain development that is otherwise normal, especially in the frontal areas, and therefore it's outgrown by many who have had normal development, but it's lagged behind so that their frontal lobes are not operating up to capacity. However, it's increasingly considered a behavioral syndrome of many causes, even with comorbidity. What I described earlier is considered a developmental ADHD, but there's also acquired ADHD. It could be acquired due to a traumatic brain injury and subsequent seizure disorder. Seizures themselves, absence seizures, can cause lapses of attention in the classroom. Prenatal substance exposure or toxin exposure can contribute. Perinatal insufficiency of nutrition and oxygen, as well as various chromosomal abnormalities. I also mentioned here mild neurocognitive disorder as an appendix in the DSM, which explains what could be going on with youth who have not only attentional problems, but informational speed slowing, informational processing speed slowing, language and learning difficulties, memory problems, perceptual motor, and executive functioning difficulties. Now, there are the other disruptive behavior disorders that I mentioned, such as oppositional defiant disorder and conduct disorder, that actually can present like ADHD features. And I'm going to go over the highlights of these, and some of these slides have underlinings of where there are features that can look like ADHD. But there are the depressive disorders that include major depressive disorder, dysthymic disorder, which is chronic lower grade depression, and the two of them combined in what's considered double depression. There are the bipolar disorders, and it's important to keep in mind that major depressive episodes are found in both major depressive and bipolar disorders. Now, major depressive features are listed here, and what's underlined are the agitation, the psychomotor agitation of depression in youth, especially younger youth, can look like the hyperactivity of ADHD, and the difficulties with concentration can look like the distractibility of ADHD. By the way, this is one point in the presentation where I'm listing all of the diagnostic criteria, 9 in all, for a major depressive episode. These are right out of the DSM-4, and we talked about them in our last installment when we talked about assessment. These are the 9 criteria that are in the PHQ-9. Now, I mentioned especially irritable young depression, that is, depression in youngsters. And we find that younger children are frequently irritable and anxious, and they'll have diminished concentration, therefore be distractible, and have more psychomotor agitation that looks like hyperactivity. They can also have somatic complaints and hallucinations, depressed appearance. With age, these features are less prominent, and there's more hopelessness, diminished interest in pleasure, delusions, diurnal variation, and psychomotor slowing versus psychomotor agitation or restlessness. The chronic low-grade depression, i.e. dysthymia, has prominent concentration difficulties that can really present like the inattentive type of ADHD. And by the way, we commonly see this kind of depression in overweight youth. Now, pediatric bipolarity has prominent irritability and lability of mood. There also can be hyperactivity, impulsivity, and distractibility in the initial presentation of bipolarity. The prominent irritability has been thought of a substantial developmental difference between youth and adult bipolarity, having a lot of irritability. Now, there's some interesting findings about how ADHD does present initially and changes with age. Mood features of depression can be the first manifestation. And often, these youth are diagnosed with ADHD before they're diagnosed with bipolar disorder. And it was an interesting review, an older review of bipolarity now, that talks about how in younger children, that is the pre-pubertal onset of bipolarity, is characterized by non-episodic, not the usual extreme ups and downs of adult bipolarity, but more continuous, very rapid cycling, even called ultra-rapid or ultradian cycling, that results in a mixed manic state. And this may be comorbid ADHD and conduct disorder in the initial presentation. And that these features change as the youth ages from childhood to adolescence to adulthood. Now, psychosis is another consideration, and generally we have more active or acute psychosis, and then the more gradual onset of early onset psychosis that's known as childhood schizophrenia. Now, actively psychotic youth who become acutely psychotic are distracted by hallucinations and delusions, the so-called positive symptoms. They can be impulsive and or hyperactive due to their thoughts jumping around and responding to hallucinations and or delusions. They can even have catatonic restlessness that can appear like hyperactivity. And there's a whole differential list of possibilities causing acute psychosis. What's often of great import in the differential diagnosis for ADHD is the insidious onset of childhood schizophrenia. Typically, there's an early emergence of various developmental and behavioral problems, followed by the gradual onset of psychotic symptoms. can present initially with depression and conduct problems. But what we see is that many, if not most all of these youth have attentional problems and hyperactivity early on that leads to a diagnosis of ADHD by elementary school, preceding the diagnosis of schizophrenia. So what we're seeing is that for the more severe conditions of bipolarity on the one hand and schizophrenia on the other, usually these kids have a gradual development of these younger than expected conditions that have presented earlier like ADHD and have gotten them those diagnoses. The significant developmental deficits in children, 1/2 to 3/4 of children studied, have been in areas of language, motor, causing soft neurologic signs, and social functioning. And academic difficulties are common, resulting in retention of half of these kids, and 2/3 of these kids are placed in special ed prior to the onset or diagnosis of psychosis. And that these kids can have peculiar social interactions and relatedness, including speech and mannerisms, that appear like they have pervasive developmental disorders, with echolalia being the unusual speech, and the mannerisms such as hand flapping. We're moving on to consider the anxiety disorders of youth, which are the several listed here. And this list is made with consideration of development, insofar as younger children are more inclined to develop specific phobias, such as extreme phobic reactions to spiders, snakes, other insects and animals, as well as other things in the environment. It's the three of them that are in bold that we're going to go into discussing a bit more here. And after making the distinction that with panic disorder, the panic attacks are untriggered, whereas in other conditions such as PTSD, other anxiety disorders, and even depression, there can be panic attacks that are triggered. Separation anxiety is a condition where one is having difficulty leaving home due to recurrent excessive anxiety, fear, or worry concerning separation from major attachment figures, major attachment figures such as parents, due to worries about harm that may befall them while away and what might happen at home. Maybe it's worries about things being too chaotic, about substance abuse. Frequently, there are tummy aches and headaches, and this is a major cause of school refusal. Often, the terminology separation anxiety used almost interchangeably with school refusal. However, depression, psychosis, and the other anxiety disorders can also cause school refusal. Generalized anxiety disorder is another anxiety disorder that can cause a picture that looks clinically like ADHD due to the characteristic restlessness and concentration difficulties. Generalized anxiety disorder can also cause tummy aches and headaches. Posttraumatic stress disorder can cause concentration difficulties, often due to the recurring, re-experienced past traumas in intrusive recollections and or flashbacks that can distract teens while they're in class. They can also be very reactive and have restlessness and outbursts that can appear like ADHD. And their hypervigilance can cause them to appear hyperactive. So can their exaggerated startle response. Now there's some memory and attachment considerations, including reactive attachment disorder has a variety referred to as disinhibited type. and that disinhibition can look like ADHD, especially in younger children. Now, I mentioned memory and attachment considerations because it's been found in research that attachment is so vital for the development of memory. And those who have very disorganized attachment actually have impaired memory formation. There are ways of identifying disorganized attachment and other attachment problems through the use of the infant strange situation to study the infant, as well as studies of the parent's states of mind using the AII, the Adult Attachment Interview. And I want to read something from the middle of this slide because in very chaotic homes and where situations have been very abusive, such as in domestic violence situations, parental fear and anger becomes very disorganizing and disorienting for the child. Therefore, parental frightened, that is fearful, frightening as in enraged, and or disorienting behavior appears to mediate disorganized attachment within a child's lifetime as well as from one generation to another. Disorganized attachment can cause severe problems with attention, emotional regulation, and behavioral reactivity. So these kids can be highly reactive, and that can cause a picture that looks like ADHD. Dissociative disorders also can present like ADHD for reasons similar to what has been mentioned earlier. Sleep problems have become such an epidemic in our society, and these can cause, signs of sleep deprivation often are misdiagnosed as ADHD because of the resulting difficulty concentrating and following directions. That can result in irritability and impulsive hyperactive behaviors. These individuals can become aggressive, they can have impaired learning and learning and academic performance due to insufficient sleep. By the way, it's been found that children who have ADHD often are found to have more fragmented sleep, though the same quantity of sleep as controls, and this is independent of psychostimulant medication. Substances can induce ADHD features. Stimulants that are taken by those who don't have ADHD can cause them to appear like they have ADHD. And substance-induced distractibility, concentration difficulties, impulsivity, and agitation can look like ADHD. And this can be during intoxication with the substance and repeated use of substances. Pervasive developmental disorders often cause youth to be inattentive, distracted, hyperactive, and impulsive. And often youth who are so-called on the spectrum, that is, the autistic spectrum, can first be diagnosed with ADHD and before they receive a PDD diagnosis. Now, there are other developmental considerations such as delayed but progressing development, learning and language disorders, kids becoming bored too easily while having trouble learning can look like they have ADHD. And of course, real young children, toddlers and preschoolers, naturally are hyperactive and distractible and impulsive. There also are a number of medical conditions having to do again with medications which parallel what I said about substances, thyroid disorders, lead poisoning, central nervous system infections, even peripheral viral infections such as EBV and other medical conditions can cause youth to appear as though they have ADHD. So that really gets through the entire list, Hernan, of these differential diagnostic considerations. And if it's okay with you, I'd like to move on because that's not all. There's comorbidity that occurs with these conditions. Insofar as our clinical assessments often reveal more than one disorder, coexisting disorders that will resemble ADHD, such as a mood disorder, depression, and anxiety disorder, plus a disruptive behavior disorder, and a neuropsych condition, such as dysthymia, PTSD, conduct disorder, traumatic brain injury. These individuals will look a lot like they have ADHD. And other disorders often coexist with ADHD. In fact, ADHD is really a diagnostic condition of comorbidity. About 3/4 of youth with ADHD have at least one other psychiatric disorder, and 2/3 of those can be oppositional defiant disorder. Now again, pediatric bipolar disorder is often found to coexist initially with features of ADHD and/or conduct disorder. So it becomes as important to assess and treat these conditions as it is the ADHD. So we see overlapping coexisting domains that often resemble ADHD, and we often see other conditions that coexist with ADHD. And there are many of these conditions that coexist with ADHD. I'm going to move on to say, so far, while we've looked at the differential diagnosis for ADHD and other disruptive behaviors and the comorbidity of these diagnoses with ADHD, there also are the contributing, exacerbating, and other associated factors. And while we talked about the medical mimics, many of those same medical conditions can often add on to what's going on with the ADHD. And so can the psychosocial factors that I alluded to earlier in the presentation. So in summary, youth referred for evaluation of and medication for ADHD frequently have other, often coexisting conditions that impair their learning, and various diagnostic domains that feature hyperactive, impulsive, and off-task behaviors need to be considered. Also, the comorbid disorders and exacerbating factors also contribute. So Hernan, as I see that we're approaching 1 o'clock, and I know that there's a meeting that's going to soon occur, and attendees for that meeting that will be opening the door shortly, we're going to fall short of reviewing the case that was prepared for today's discussion. This is something that I'd be willing to discuss with you individually through I'm just going to go through here and say we could discuss it again at the next TPICC session. Also, I'm available for consultation, whichever way you want to proceed.
I think it would be great if we could do it at the next TPICC session.
And if there are others who are with us that day who didn't hear the earlier part of the presentation, would it be okay with you if we begin with that?
Review. Absolutely. You can go over this stuff as many times as you want. The more the merrier from my perspective. And actually, I wanted to ask you if you could give me a way of, so that I can review what you've spoken about, because I take my notes, but they're incomplete usually.
Absolutely. Absolutely. The PowerPoint will be available at the envisionnm.org website. So as you look here at the bottom of this slide, further information at envisionnm.org. And in fact, as I go back to the TPICC, yeah, it's not there. So I'll point out to it here. And then if you go to, actually just go to our calendar and click on today's session, the PowerPoint will be there, if not this afternoon, I think by tomorrow.
Perfect, perfect. And let
Great.
me tell you, this is a fantastic presentation that really gives you a very nice picture of what one should be looking into. I really appreciate this. This is very enlightening.
Well, that's fantastic. You're such an enthusiastic participant, Hernan. It's really a pleasure getting to interact with you.
Well, it's my pleasure too, Dan, and thank you so much for taking the time.
Likewise, Hernan, your participation is really valued. It's great having this time with you today.
Very good. We'll be talking to you at the next session then.
Sounds good. That will be Wednesday, February 6th at noon.
Very good.
Okay, until then, you take care.